Hello, hi, I'm Dr. Mousa, Hayat Mousa, professor in pediatric at UCSD, University of California, San Diego, Rady Children's Hospital. I'll be covering constipation in children today. No financial disclosure. I would like to recognize Dr. Ashish Gogel, who really made the slides, prepared the slides, and I would like to recognize Neurogastroenterology and Motility Committee and NASPGHAN for sponsoring this project. So, at the end of this part of MOC, the participant will be able to recognize the broadness of functional constipation and the definition of functional constipation. The participant will be able to assess and manage a child with functional constipation, determine when to refer, what to do before to refer, and then discuss the long-term prognosis of childhood functional constipation. The participant will be then able to start a quality improvement project to improve the constipation management in youth. Constipation is a common problem indeed. It is common, and the prevalence is 1 to 29% in general population. We see that constipation is a diagnosis in 3 to 10% of visits to the general pediatrician. It makes up to 25% of pediatric GI visits. 8% of school-age children in the US have constipation, and they have lower quality of life when they were compared to healthy children and children with IBD or with gastroesophageal reflux. The constipation is functional in 90% of the cases in children. Constipation secondary to organic reason occurs only in a fraction of patients. Now, to meet the diagnosis of functional constipation as from 3 criteria or definition, patient should have 2 of the following for at least 1 month. So Rome 3 criteria would say the list 6 items, and the patient should meet or should have 2 of those for at least 1 month. So the 6 items are, the first is 2 or fewer defecations per week. 2 or fewer defecation per week. At least 1 episode a week of fecal incontinence after the acquisition of toilet training. Then, history of excessive stool retention, history of painful or hard bowel movements, history or the presence of large bowel movement or fecal mass in the rectum per exam, or a history of large bowel movement with possibly obstructing the toilet. So these are the Rome 3 criteria. Patients should meet 2 of these criteria for the past months or for at least a month. How do we approach patient or a child with constipation? We have to review again the history and physical exam. Review if there are any red flags. Check if the patient is impacted. Then start with maintenance, therapy, and education. We will address also the need for possible labs or possible consultation. In the history, the first question is the passage of meconium. So normally, patients should pass bowel movement the first day in up to 90% of the patients. The meconium should be passed the second day in 97% of the kids, and on the third day by 99.8% of the kids. So meconium passage should happen the first day in 90% of the kids, second day in, again, 97% of the kids, the third day in 99.8%. 50% of children with Hirschsprung disease will pass it on the second day. So we have to keep this criteria in mind when we ask about the passage of meconium. The second question will be time of onset. So we'll ask the parent, when did your child start having constipation? And in functional constipation, 10 to 40% of the kids will start the constipation or they will have symptom of constipation the first year of life. Also, we will ask about toilet training because a majority also, a good number of kids with functional constipation, the symptoms start at the time of toilet training or when we introduce solids or when we change from breast milk to formula. The onset of symptom also important in older kids because if the constipation starts later in life with the sudden onset, that should raise the suspicion or the reason to ask about a history of abuse, child abuse. Now, for the history, also we ask about stooling, about the frequency, how often your child go, and then the size. So for frequency, it will be good to know what's a normal. The normal frequency of bowel movement varies. In the newborn, the first week of life, we might see up to 4 bowel movements a day, and that will trend down. So by age 4, they might have 1.2 a day by age 4 years. In the breastfed infant, also they might have 1 bowel movement every 2 to 14 days, and they might have 4 to 5 bowel movements a day. So the range of normal frequency of defecation really wide. In healthy toddlers, they might have 1 bowel movement every other day, and that's within the normal range. Other than the frequency, we ask about the size of stool, the size of the poop. Is it large? Does it clog the toilet? So the larger bowel movement, the bowel movement that clog the toilet associated with holding behavior, all these point toward functional constipation in the history. Then we ask about fecal incontinence, and it's very prevalent. So we see fecal incontinence in up to 4% in general in the community, but we see it in constipated children way more often. It is up to 80 to 90% of constipated children, they will have fecal incontinence, and about 80% have retentive posturing with the fecal incontinence. The fecal incontinence in constipation is due to overflow, the mechanism of overflow, and can be misinterpreted sometimes with diarrhea as if it were diarrhea. So questioning and verifying fecal retention with the fecal incontinence extremely important in the history. We ask about abdominal pain too, and abdominal pain is common in patients with constipation. It's a nature of vague chronic pain that worsens with the retention and get relieves or improves with the defecation. Other parts of the questions or the history include urinary incontinence. So we need to ask about all urinary symptoms. And evidence show that daytime urinary incontinence is common in 29% of the kids, and bedwetting in 34% of the kids. UTI, urinary tract infection, range between 3 to 33% of the kids. So we should ask about urinary symptoms every time we see a child with constipation or fecal constipation. Behavioral problems also common in children with constipation, especially in kids with constipation and overflow fecal incontinence. It is not clear whether the encopresis or constipation caused a behavioral problem or behavioral problem contributed to the etiology or to the withholding behavior, and there is a vicious cycle between the behavioral problems and the constipation and encopresis. However, reduction in the behavioral problem with the treatment of constipation and encopresis always seen. We ask about dietary habits, including fiber and liquid. So constipated children were found to have lower fiber intake than healthy children, and additional water intake can increase the stool frequency only if their voluntary fluid consumption was less than normal. So if a child seen in the clinic and not taking enough liquid, if we increase the fluid intake, it will increase the stool frequency. In the history also, we check for review of system, we check for family history. In the review of system, we have to ask about possibility of thyroid disease, parathyroid, keep in mind kidney disease, and cystic fibrosis. Family history is very relevant. If the family history is positive for Hirschsprung disease, celiac disease, food allergy, and thyroid dysfunction. After doing the history, complete history, we come to the physical exam, and we have to do complete abdominal exam. We need to do a spinocerebral exam to look for anomaly and deep tendon reflexes, check for how brisk they are. Then digital rectal exam or anal exam first, looking for fissure, anal wink, looking then by the digital exam for the tone of the sphincter, anal sphincter, looking also if fecal impaction, if retention in the rectum, and maybe testing for occult blood in this case. However, study showed that, and evidence showed that there is no evidence to support the use of digital rectal exam to diagnose functional constipation. We can skip digital rectal exam if the abdominal exam reveals suprapubic or left lower quadrant mass, or if the patient may have 2 or more criteria of the ROM3 to fulfill for functional constipation. So we may skip rectal exam in that case. We should do the rectal exam if only 1 criteria is present and patient does not meet the diagnosis for functional constipation, so a digital rectal exam should be performed then. In general, what are the red flags on exams? So general exam, if we see a patient with coarse skin, hypotonic, tachycardic with severe abdominal distension, we have to consider hypothyroidism. In the perineum exam, we look also for, again, perineal fistula. We look for the position of the anus, if it's anterior or not. We look for the patient being very fearful of the exam. That also raises a concern for possible abuse. We look for anal scar. That also raises a concern for possible abuse. We look for the absence of anal, the wink reflex, or the cremasteric reflex. So perineal exam is extremely important, and the red flag can be seen during the perineal exam. The other part in the exam that we might find red flags is lumbosacral exam and the lower extremity exam. So at the lumbosacral area, we look for any kind of tuft of hair on the spine or sacral dimple. We look for any type of lipoma or gluteal cleft deviation or flat buttock. All these point toward possible tether cord or spinal cord anomaly. Then we check lower extremity, and if the lower extremity tone and the reflexes with the strength decrease, that also raises a concern for possible spinal cord anomaly. So the red flags for symptoms, as we mentioned before, what would make us concerned that it might not be functional constipation if the meconium was not passed for more than 48 hours. Or if the constipation started early in life before or during the first months of life. If there is family history of Hirschsprung disease, if the patient is passing ribbon-like stool, if there is blood on the stool with no evidence of fissure by exam, then if the patient is sick, if he has fever, bilious vomiting, if he is failing to thrive, we need to consider organic etiology for constipation, not only functional etiology. Do we need to do lab? That's a big question. Again, if the patient meets the criteria for functional constipation based on ROM3 definition, no need for lab testing, no need to check for hypercalcemia, hypothyroidism, or celiac disease. So that's not recommended in the absence of alarm sign, in the absence of red flags. What about abdominal films? So in regard to the utility of X-ray, there's insufficient evidence for association between symptoms of constipation and the fecal load on abdominal X-rays. The sensitivity of abdominal X-ray in diagnosing constipation in children range between 60 to 80% with very low specificity, which is 43 to 90%, wide range. So it can be done, the X-ray can be done if the child refuses exam or the child is obese. We cannot assess for any fecal retention or abdominal mass on exam, or if we have to do the rectal exam to complete the diagnosis and the patient refuses. So patient is not cooperative, there might be a use for abdominal X-ray. So after we reviewed the history and physical, we went over the red flags and went to possibly suspect more testing. We will address now the therapy. The therapy or treatment, we will go over 2 parts. Initially, that is disimpaction, and the second part will be the maintenance of therapy. So for the disimpaction, the recommendation now to use PEG orally, 1 to 1.5 gram per kilogram per day for 3 to 6 days. That's recommended for children presenting with fecal impaction. So either by abdominal exam or rectal exam, patient is definitely impacted, we will start this course of PEG. If PEG is not available, then enema once a day for 3 to 6 days till we provide disimpaction for the patient who is impacted. PEG is as effective as enema but can cause more fecal incontinence. So if patient is known with fecal incontinence, then we might elect to use the enema instead of the PEG if fecal incontinence increased with the use of PEG. For the maintenance, again, PEG is recommended as a first-line maintenance therapy. The starting dose is 0.4 gram per kilogram per day. That's a recommended dose, and the dose can be adjusted for a patient based on the clinical response. If PEG is not available, the second medication we can consider is lactulose. That lactulose will be recommended as first line if PEG is not available for maintenance therapy. Use of milk of magnesia, mineral oil, and stimulant laxative may be considered as additional or a second line therapy. Maintenance therapy also, we encourage fiber, and patient may take amount of fiber that equal to his age per year plus 5 as a gram of fiber per day. So, and fluid intake then can be also, it's recommended to take a routine fluid intake per age. Routine use of prebiotics and probiotics is not recommended. Association of cow milk, protein, allergy, and constipation is still debatable. And a 2 to 4 week trial of milk-free diet can be also recommended in part of the treating intractable constipation. Duration of medical therapy, that's an extremely important point here because the maintenance therapy should continue for at least 2 months. The other point is all symptoms of constipation should be resolved completely for at least 1 month before we consider weaning or decreasing the dose of medication. The other point is that treatment should be, when we are ready to decrease, should be decreased gradually. And the medication should only be stopped once the toilet training is achieved. So there are certain criteria for when to stop, not before 1 month of having free symptoms, and then how to stop it gradually, not to be abrupt, and to achieve toilet training before we decrease or we start decreasing the medication. Education is a very important part in the management of children with functional constipation. So we explain the pathophysiology of encopresis to the parent and to the child. We suggest that the patient will sit on the toilet 1 to 2 times a day for 5 to 10 minutes. We strongly recommend that the patient or smaller children will have step stool. We will use positive reinforcement and never punishment for children as we are treating them for functional constipation. Part also of the education that we provide the family with written home management instructions. And then we assess the progress and provide encouragement and guidance for these parents or for the child. Prognosis is also important to consider when we are managing patients with functional constipation. As for provider, we need to understand that 1 year recovery rate for children from functional constipation was approximately 40%. 5-year and 10-year recovery rates were 50% and 80% respectively. 50% of children had at least 1 relapse within the first 5 years after initial recovery, and the other part that 30% of children continue to have constipation into adolescence. That's a prognosis frame that we need to manage our patient based on. And the other part that any delay in managing constipation after initiation of after onset of symptoms for more than 3 months, then that will correlate with longer duration of symptoms. And it seems of great importance to follow constipated children closely and restart medication promptly if necessary if they relapse. So if refractory, and we applied all these type of disimpaction therapy and then maintenance therapy, we consider education and dietary changes, and we still have refractory constipation, we need to reassess. We need to adhere or check that patients and parents are adhering to the recommendation. We may consider re-education, we may consider different dose of medication, we may consider different medication, and then consider if the patient is still having impaction and we have not addressed that. So consider untreated fecal impaction and consider mental health issues or that we have not addressed, and they consider consultation with mental health providers for that. If refractory and we provided all of the above, then we might consider laboratory testing, and then we might consider referral to pediatric motility specialists to assess the motility in this patient. A method of improving the quality based on this, that we self-evaluate, self-evaluation and reporting, identification of benchmark and standard, then additional training and education. The next steps, MOC Part 4, activity focused on constipation, evaluating documentation of essential elements of constipation assessment and management. We document, we evaluate the documentation, then completing 10 patient case-centered data reports where care for constipation occurred at each data collection cycle. And about the format, PowerPoint slide presentation with accompanying video. We will have the knowledge assessment, data collection, feedback, and quality improvement. The other part that we have MOC Part 2 credit. So we are also offering MOC Part 2 credits. It involves reading scientific articles regarding constipation. Then, if completed in full and answer at least 75% of the 50 questions correctly, 20 MOC Part 2 credits will be awarded. So in conclusion, in 90% of the cases, diagnosis of functional constipation is based on history and physical examination. Alarm signs and symptoms should be used to aid the diagnosis of organic constipation. The disimpaction is a very important part of the treatment plan for constipation. And in summary, there is variation, and variation in constipation assessment and management between practices exists. Improving the performance is a key step in improving care quality, and future studies needed to validate selected benchmarks in constipation management. At the end, I would like again to acknowledge Dr. Ashish Gogol for his contribution and making the slides. I would like to recognize the Neurogastroenterology and Motility Committee of NASPGHAN, and I would like to recognize North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. Thank you.